Hello, my name is Kyle Rehder. I'm a pediatric intensivist at Duke Children's Hospital, and I'm an editorial board member for Respiratory Care. Today I'm going to be talking as part of the series that we're doing of favorite articles from the last year. So one of the favorite articles that I had over the last year was driving pressure as a risk factor for ARDS in mechanically ventilated subjects without ARDS by Oriol Roca and colleagues. This was published in Respiratory Care in October of 2021. This study was done as a post hoc analysis of an international prospective multicenter trial, starting out with 1,575 subjects whose primary inclusion criteria was being mechanically ventilated for at least 12 hours. None of these patients initially had ARDS, however 65 developed ARDS within 28 days, for a total of about 4% of those subjects. When they went back and looked at the initial driving pressure on that first day of mechanical ventilation, that was independently associated with ARDS development. And you can see that there's an increasing stepwise fashion of risk with each additional centimeter of driving pressure. More so, these same results were observed at day 2, and similarly, delta P was also associated with ICU and hospital mortality. This is shown in these two figures, which take the subjects and divide them into quartiles based on their driving pressure on day 1 of mechanical ventilation. The figure on the left clearly shows that as driving pressure increases, so does the adjusted odds ratio of developing ARDS over the first 28 days. On the figure on the right, you can follow those quartiles over those 28 days and look at their cumulative probability of developing ARDS. It's very clear that with greater driving pressure, you have a greater cumulative probability of developing ARDS, and it is in fact a stepwise fashion based on that driving pressure difference. So why does this matter, and why did I choose this as one of my favorite articles from the past year? We've known for quite some time that lung protective ventilation is the key to managing our ARDS patients and preventing ventilator-induced lung injury, which is going to be a driver of mortality and morbidity in these patients. We also know that in addition to biotrauma and atelective trauma, barotrauma and volute trauma are two of the biggest factors in that ventilator-induced lung injury. And we know that these don't exist in isolation from each other. Larger volumes mean higher pressures and vice versa. That being said, there's been a fair amount of discussion about what is it that causes the most injury to the lungs. Is it that peak distension, or is it the tidal stretch, the driving pressure for each individual breath? And there's been a fair amount of data that's come out recently that shows the importance of tidal volume and driving pressure for these ARDS patients. And if we can bring that driving pressure down, it's going to be better for the lungs. What this study adds is that we have to consider both of these, and particularly delta P, even in healthy lungs. It's not just ARDS patients. We need to be thoughtful about how we ventilate healthy lungs to prevent the development of ARDS. Hopefully you found this useful and interesting. If so, please check out more respiratory care pearls on our YouTube channel, on our Twitter feed, and on our Facebook page linked here.